So within the FIRE4 study, we were investigating two endpoints, so we had two randomizations. The primary endpoint, which will be overall survival after randomization 2, is basically analyzing the question whether cetuximab re-challenge in patients that have responded to cetuximab early on is meaningful or not. This is still ongoing and it's still on follow-up, so we do not have the data on this part of the study so far. What we have talked about at this year's ASCO was the influence of baseline liquid biopsy in a RAS wild-type metastatic colorectal cancer population treated with either FOLFIRI plus cetuximab as a standard arm until progression or intolerable toxicity. And this was randomized against FOLFIRI cetuximab as induction treatment for a total of 8 to 12 cycles. And then we applied a switch maintenance containing of 5-FU capecitabine and bevacizumab. Within the liquid biopsy program, we did a baseline liquid biopsy and also follow-up liquid biopsy, especially at the end of the treatment or at the time of progression, to get a better insight about the meaning of liquid biopsy in this setting. Quite unexpected, we found 13% of the liquid biopsies positive for a RAS mutation. So also it was a RAS wild-type population by tissue analysis. We found an addition of 13% of RAS mutant cases. And those cases actually had clinical outcomes according to a RAS mutant population. So at baseline, we have a very strong prognostic and prospective value of the liquid biopsy. Furthermore, as expected, we were able to detect around 7% of BRAF V600E mutant cases. Again, those cases had outcome parameters according to a BRAF V600E mutant patient population, with a very short progression-free survival and a very short overall survival, as I said, as expected for this kind of patient population. We have seen a lot of development when it comes to liquid biopsy during the last 5 to 10 years. So the sensitivity has become better. Also, there are more and more commercially available vendors where you could just order such kind of an analysis. And the big question right now is, what is covering the real tumor population better, liquid biopsy or tissue-based biopsy? As we were able to carve out another 13% of patients that do not benefit from anti-EGFR because of the RAS mutations that we were able to detect, it's probably good to do both if possible, to do a tissue test first and then in addition a liquid biopsy test. In my opinion, in the future, especially if tissue testing takes a lot of time, maybe we will be able to replace tissue-based RAS testing by liquid biopsy testing, which is just more convenient and way faster to get the results.